Good afternoon. Welcome, everyone. And the Hospital Systems Addiction Care Community of Practice is a joint venture between the New Hampshire Technical Assistance Center, which is run by Growth Partners, and we welcome Kai and Katie and Drew. I think for a couple of those folks, it is their first time here. It's also my employer, the Foundation for Healthy Communities, and the Bureau of Drug and Alcohol Services at the New Hampshire Department of Health and Human Services. Today, we're going to be working on identifying strategies for defining meaningful metrics in substance use care, improving reporting accuracy, and designing workflows that help teams better identify, manage, and coordinate care for individuals with substance use disorders. I am very pleased to welcome to our community of practice Casey Bukowski, who many of you already know. I have the great and high privilege of working with Casey as one of our project hospitals. Casey is a behavioral health informaticist with a background in population health project management, value-based care performance, and EMR workflow design. She brings nearly a decade of experience translating complex clinical programs into practical operations. Casey has designed self-service dashboards, reporting frameworks, and data-driven workflows that improve access and engagement and support and regulatory compliance across hospital-based SUD and behavioral health programs. Casey, it is a pleasure. I have known you for several years through this project work. I absolutely love your quarterly reports that are so very data rich, and welcome to the community practice.
Thank you. Thank you, Dan. As Dan said, I'm Casey Bukowski. I am a data analyst for the Department of Psychiatry at Dartmouth Health. And I'm excited to be here. I did tell the group before starting that as a data person, my public speaking skills, I think, have probably gotten a little rusty as time has gone on. But I'm really happy to be here and share some of my practical insights and lessons learned as I've tried to build better data systems for substance use disorder care. So jumping right in, new data from SAMHSA 2004, New Hampshire substance use disorder burden is comparable to the national average. But that continues to put significant pressure on our community providers and hospital systems. Our burden is lower than some surrounding New England states. And I might go as far as suggesting that our collective efforts on substance use disorder treatment is making a measurable difference. However, the treatment gap still remains a profound challenge, not just for us in New Hampshire, but nationally. So about 1 in 5 residents who are identified as needing substance use treatment received care, or fewer, I should say. So however much burden we're experiencing now as a community and hospital systems to deliver care, there's still many more folks out there who could benefit from treatment. So New Hampshire has made targeted improvements to strengthen how we deliver substance use treatment, looking at universal screening, integrated treatment, care coordination, and social care linkages. Even so, the treatment gap probably isn't much of a surprise for a lot of us on the call. Substance use care is complex. It's a maze of emergency departments and primary care, specialty treatment programs, social services. And I feel as though that complexity paired with our continuous um, drive to improve the delivery of care, we have the best intentions, but it can lead to fragmentation. And fragmentation in our care delivery gets translated into unusable data. And even if you don't work with data directly, I think that the result can be frustrating for everyone. Um, I know often the providers that I work with and the clinicians, they feel as though they do more documenting than interfacing with patients. And I can speak as an analyst, I spend more time cleaning data than I actually do interpreting it. So there's still a lot more work to be done. But we have made lots of improvement, and I do as a state, and I do think that it is making a measurable difference. Um, and getting into how to look at data, because we still need to use the data to progress this work forward. And the data is not perfect. It's very messy, hence how busy this slide is. That's intentional. Um, and so how can we use that data given the current state of fragmented care, the burden being high, um, but also it making a difference and wanting to, learn from those efforts. So I found it helpful to think about data in two broad categories, operational and educational. And a lot of times what I see is health systems wanting to have data in one category do the job of data in another category. And that can be a major source of burnout. So I see operational data as transactional. It moves work forward. So thinking, patient registry to manage patients or a referral work queue, whereas educational data I see as orienting to help us. It provides context, um, and that would be like slides that we just went over, prevalence rates or early warning indicators. Um, And the vital overlap is what I'm calling informed action. And so this is where I feel that the data lives that supports decision making while simultaneously guiding how we adjust the improvement efforts that we're making. So standards of care, national benchmarks can come out of that overlap. So how do we get reliable data from the execution of clinical guidelines or treatment models or evidence-based programs that are hopefully built within that overlap of the informed action? Um, I have a bit of an unconventional application. So my approach is nothing radical, nothing new, analyze, improve, control. But the way that I apply that is a bit different in that I work intentionally small. So smaller than would be expected in traditional project management. Traditional project management expects that we define the full scope up front, um, typically, involving um, all stakeholders at the table, and I have found working small actually has um, kept momentum up for something as complex as getting reliable data out of the treatment that we provide. So, to clarify, that doesn't mean that I work alone. Um, it just means that I apply the approach narrowly and really deliberately. Um, so an example, I'm currently working with a research team, um, and it consists of a coordinator, a project manager, and a scientist. So those are the folks that I interface with. They've got some complex data needs for an NIH study. So I translate between the study group and IT, database developers, EMR builders, and when necessary, I bring us together. And then in turn, the coordinator, the project manager, the scientist, they liaison between the principal investigator of the study, the clinical director of the program, with targeted questions, specifically asking for decisions to be made around what's come out of the data validation that we do. And so, one population, one program component, short iterative timelines. Um, I keep the work group lean, um, three folks that are decision capable. They don't need to be decision makers, but they can help facilitate getting answers made on what we're finding, engaging IT early, continuously, bringing us together when needed. Um, and then alignment, assuming documentation variability and escalating or elevating constraints that surface through the data validation when necessary. And, you know, with evidence presented really clearly for leaders to react to. I have worked, in a more traditional project management um, forum with data, and those projects have can go on for years. Um, and it's really hard because definitions will continue to shift. Um, the logic is really not defendable. We need a bunch of footnotes to try and explain what we're capturing. And so keeping all the stakeholders involved, but in smaller groups, I found helps us align um, and maintains momentum. Um, and so, in addition to how I apply the approach, I also just have some guiding principles around flow and infrastructure. Um, so I think about data systems the way I think about a municipality and how they distribute water. So an infrastructure designed to deliver something safely and reliably. And so availability does not always equal usability. And so just as water needs to be treated before it gets distributed, so does data. Um, and so that is how I think about data from, an infrastructure analogy and some guiding principles. Most importantly, clinical documentation tools are should really be designed for care delivery first and then measurement second. Um, Variation can be used as a learning tool. Once it's understood, we can use data to justify standardization, but we really want to apply standardization where it matters. So where it actually improves care, improves performance. If we apply standardization too early in the process, we're not really getting a good sense of like reality. And the third principle is that the shifts in data flow really should serve as indicators of intentional decisions that we've made about our data management system and shouldn't represent a reflection of the fragmented care that we talked about in the beginning. So I do want to elaborate on the third principle, that the flow of data needs to be intentional. So before data is released to support a workflow, we have to define these control points. And that's going to ensure that the information is relevant, it's safe, and it's usable. So when data within a management system slows down or it accelerates or it branches off, again, that should indicate an intentional decision that we've made. Um, if we, for an example, aren't thinking intentionally about the flow of data and it's the sources kind of flowing out there, we might react, have like unnecessary false alarms. We might react to something that might be interpreted as a problem, but it really isn't. Or um, conversely, we might feel overconfident in something we've implemented if we're not being intentional. So we want to think about who sees what, when, and in what form, and then how do we balance the flow of information considering, staffing and operational capacity, because it can just be a additional like cognitive load, I think. So this is the framework in which I view data and interact with it and apply it to, the projects that I'm working on. So to illustrate how some of that looks in real life, I wanted to look at a few specific examples. So the first is focusing on substance use disorder screening within the emergency department. So this was a improvement initiative in collaboration with the Foundations for Healthy Communities, as well as Dr. Lanter in the emergency department. And the goal was to improve early identification of substance use in the ED, and then in turn, support timely referral and care coordination. Our intervention for doing that was really focusing on the brief negotiated interviewing techniques that came out of motivational interviewing from Boston University. And so we provided really robust training to the registered nurses on the ED floor. Um, from a data perspective, we wanted to leverage the current workflows that already existed there, that were already being generated, during the course of care, and not add documentation burden to the nurses. It was pretty amazing, the results. We saw a increase in our screening and referral rates, and something that we hadn't um, expected or factored in at the beginning of our project. One of the data points was whether a patient accepted a referral or accepted Narcan. And so we started our trainings in October. They ended in April. So you can see, um, you know, the increase in screening, referrals, and Narcan. Um, but we also noticed that folks were more willing to accept the referrals, and a bit of an increase in accepting Narcan. In May, performance around screening rates went down. Um, However, those who screened positive continued to stay up. And so my thinking on this is that, after April, when, the project team has packed up and left, it's hard to sustain those changes, keep them at the forefront of, all the different things happening in an ED. But the way in which the nurses were having the conversations around screening, using the brief negotiated interviewing, didn't change for those who were doing it. And that really seemed to have an impact on patients' response to be truthful or to accept the referral. So this was really an exciting project for us. And the next project that I wanted to go over has to do with outcome metrics. This is specifically for challenges integrating for integrated treatment. So we specifically wanted to measure clinical outcomes for our collaborative care program. So collaborative care, we embed our clinicians into primary care to, provide behavioral health, which includes substance use disorder. And this program is different from the ED project in that, the ED project was quite a small improvement initiative that had a short shelf life, whereas COCM at Dartmouth, we've had that for over a decade now. And there's this growing frustration of, we provide this care and we are having a difficult time being able to see impact that it's having on patients' conditions. We know that it works. There's been a lot of studies done, but we want to know about our own program. And so we needed to establish measures for engagement, duration, symptom improvement. And so because it's an established program, it's been going on for a long time. A lot of those clinicians are the same ones that have been there from the start of the program. And so there are documentation practices that, you know, are individual. So there's a lot of variation essentially. And we didn't want to change our program execution. We didn't want to add additional burden to the clinicians because this is such a administratively burdensome program. We want to make sure that they can focus on providing the care as opposed to just checking the boxes. So we wanted to make sure that we were creating metrics that weren't going to change a clinician's workflow. In order to do that, I had to partner with a database developer and use coding to sequence the data to reflect the intended pathway. And so going back to my principles around variation can serve as a learning opportunity. And then we can use data to standardize, get closer to, all of the clinicians throughout the system, using the documentation tools in a standard way. So, we would set a metric and we would say, this doesn't look like it represents, what's happening out there. But we set it to what we want, those data elements to mean. And so as we communicate and educate on our metric definitions, and educate our clinicians within the collaborative care program, we know that over time it's going to smooth out. But it requires a lot of iterative testing around the metric definitions, accepting a level of noise or finding ways to eliminate noise from the denominator and the numerator. And then validating those outputs with the clinical directors, with the behavioral health clinicians. And folks have been trying to do this for as long as the program has been around, and not until we focused on one population, because we provide collaborative care to adults, pediatrics, and the geriatric population. And until we just scaled it down to pediatrics and we scaled it down to outcome metrics and not process metrics, such as how many referrals are we getting, and we are just looking at outcome metrics, we were really able to start making a dent in this work, which has also been really exciting. And so this is a image of our dashboard. It's a lot of information, so I just took a section of it to highlight. So this is available to those in the system, population health, Department of Psychiatry, primary care. And so this particular metric is response at completion of care. And that's defined as having a greater than 50% reduction in their symptoms. Um, and this was really complicated to try and suss out because um, if a patient hadn't received a baseline um, validated screening, so for depression, the PHQ, then they're not in the denominator. And also, what does it mean to complete care as it relates to care coordination, to a collaborative care program? So engagement was also a really difficult thing to define. Um, but we were finally able to get there. We now have something that we can strive to do better at, where we just didn't have that post before. Um, and those are my two examples. I think the last thought that I have on data as it relates to ma data management systems is resource investment. Um, so, ultimately care, especially behavioral health care, substance use disorder care, is really driven from a clinical perspective based on symptom response. And symptom response is patient reported a lot of the time in this specialty, and that is inherently data driven. And so effective reporting isn't just going to come from software alone. It requires substantial investment in subject matter experts, training, compliance alignment. And so what I've shown here is just an example of one population, one program, and one data management system that we're working on for the New Hampshire Lebanon doorway system. And in the blue is those represent people resources. And in the green, that represents technology resources. And in order to get through the entire flow, um, and to also maintain some of the improvement work that's being done, significant investment needs to be made by health systems. I think EMR modification can support care teams without increasing the burden of documentation when we design it intentionally. And not only can we improve the support that care teams have for documentation tools, we can also improve the integrity of the data. Um, but of course, it's not easy, like many things in healthcare. So, thank you for letting me share my personal insights and lessons learned. I'm happy to take any questions.
All right, thank you, Casey. If there are any questions, feel free to unmute and ask in the or put in the chat. Um,
I've got one, Drew, if you wouldn't mind. Casey,
do you know what? I
awesome.
can't
Thank
hear. Let
you.
me just put this back on. Go for it. Sorry. Go.
Yeah, I'm just curious what your experience has been in getting data entry buy-in, right? Because junk in is junk out. Like you spend so much time filtering. I run reports on ED admission diagnoses and I can't get a clear, like how do you I think this is the ultimate question, right? How do you get people to care about the data they're putting in so what we take out is useful?
Yeah, I think two things. One, if you can use the idea around data as a means to standardize. So is there a way to show what your performance is with all of that variation? And if
Mm,
you were to display that and explain, like, we're actually doing a lot better than this, but we can't really quantify that because of the variation. And so that's like the third, um, no, I'm sorry, that's like the second principle around, you know, variation, using it as a learning opportunity. So, what is happening in reality that is causing um, that? And I think our instinct is to just kind of put hard stops and put um, standardization around the documentation tools that clinicians or providers have. Um, but I think that if done short-sighted or without buy-in, we can actually start to degrade um, the meaning of what that element means. So maybe not so much
mm,
diagnoses, selecting a diagnosis, but thinking at a program level. We have, these forms that, and we use the data captured in the forms, and we have when someone was enrolled, when someone became, active, when someone um, consented. And so even though we've put these hard stops around, you need to use these, if we're at this point, they actually don't mean anything. They're really not useful at all because they're being used differently. And what one person feels enrollment is equal to being active. Whereas someone else says, "Oh, you're enrolled and you're pending and I'm, working to get to that active spot." So in a case like that, you can work with a database developer, a coder, who, if you have an operational subject matter expert around the program, who can explain, um, this is how we want to define it. And then you can display that data. And if someone's like, "Oh, that doesn't really align with my experience," it's like, well, here are the data definitions.
mm.
Are you using enrolled in the same way that this person is using enrolled? So um that that's where I've gotten the most. But I would say, just to your point, Peter, that I really enjoy my job, and I there's a lot of benefits to the role that I'm in. The biggest barrier that I have is this buy-in. And that alone can take years to build these relationships and, get folks to trust me that I'm not just going to add 10 more clicks for what, and so, yeah, I don't have a quick answer. But relationships, ensuring people know that I am not a clinical person and I don't put the data capture of a clinical tool ahead of the clinical tool being used for providing treatment or documenting that treatment. And, consistently modeling that, I've gotten trust from folks. But yeah, it's taken time. Thank you for your question.
Of course. Thank you.
Do we have any more questions?
If anybody has similar projects that they're working on in terms of substance use disorder screening or program, a behavioral health program performance, and seeing how your program's performing, I'm happy to meet and, get into the nitty-gritty of, how we've defined things we've included, excluded. So yeah, feel free to reach out.
And if there's nothing else, well, we offer a sincere thank you for appearing today and joining us, and thank you, Casey. Thank you, Dan. And you can visit us at nhtac.org. And we'd be very appreciative if you could scan this QR code and leave us some feedback. That is always important, so we can make these experiences better for all. And unless there's any last minute questions, in the chat, hold on. Oh, just thank you to Kath. I thought I might have missed a question, but thank you, Casey. And if there's nothing else, thank you very much, everyone. Happy holidays, and we'll see you in the new year.
Thank you.
Thank you all. Bye now.
Thank you. Thank you, Casey.
Thank you, Casey.